Hello, my name is Dean Contover, and this is The Current Buzz. Today we have Dr. Raj Deverajan. I always blow that name, right? But he's one of the best doctors in the Boston area, according to Boston Magazine. He was 2019 and 2020, he was dubbed the best top doctor. Is that what they call it, the top doctor?
Top doctors, yeah.
I want to know how that happens. I mean, I see that, every year there's the top doctors in Boston Magazine.
Right.
Now, do you know someone?
Yeah,
or
if you find out, let me know, because I don't know either.
Oh.
It's not something you apply for or you look for. It's done. I don't know the process. I imagine somebody thinks of you and nominates you, and they do research on your credentials and your practice. I imagine that's the process, but I really don't know because we never contacted anybody. Anybody that has been a top doctor I've talked to, they also don't know how.
Oh, okay, good. I didn't know whether there was some, backroom deal or something like that. They came out to your office and asked you questions.
Nobody came to my office.
Everything.
No, nothing.
Oh, well, that's good. I mean, your major thing is colonoscopies, right? You are involved with Middlesex Digestive Health Center in Acton, Massachusetts.
Right, so we started Middlesex about 25 years ago, and about 15 years ago we started our own endoscopy center in Acton, Massachusetts. So we had the practice for 25 years, but we opened our own endoscopy center about 15 years ago. And so there's a practice side, which is Middlesex Gastroenterology, and then there's Middlesex Endoscopy Center. So together it's Middlesex Digestive Health.
Okay.
We have 8 gastroenterologists. And when you say your main thing is colonoscopy, well, I'm a gastroenterologist like all others, but in gastroenterology, colonoscopy is the most performed procedure, and is certainly the most important life-saving procedure, life-sparing, meaning, for colon cancer screening.
Right, okay. So let's say colonoscopy, I read something in the New York Times where it says now the age was 50 and above, now it's dropped down to 45. So and possibly lower, or? So
what they used to do was, first of all, you have several associations recommending screening.
Okay.
American Cancer Society,
okay.
The society for that organ, for instance, ours is American Gastroenterology Association. For urology, it could be American Urological Society or Association. So they recommend certain screening guidelines. What most insurers or other people follow is either Medicare or United States Preventive Services Task Force. And they sort of accumulate all the data and suggest, okay, this is when it should be done. So what you read was the American Cancer Society had moved it from 50 to 45 to start screening.
Right.
So just to give you a little background, the thought was that the majority of cancers occur from 50 to 75. So you have to look at screening, but you also look at costs for doing all of these screening procedures. So they have to decide on an age when to start. So they decided on age 50. This was decades ago. But they also put a caveat in there that if you have family history, that is, your first-degree relatives, any one of them, or 2 second-degree relatives, or if you were to have another condition like inflammatory bowel disease, then you are at a higher risk category and should be started at age 40. Furthermore, they said that even if you're not meeting these guidelines, if you have symptoms that are concerning 10 years before the screening guidelines takes place, then you should consider a colonoscopy. So they had these buffers in there not to miss that 10%, because we said 90% of cancers occur from 50 to 75, so we don't want to miss that 10%. So they had these buffers to make sure that people who need to get screened get screened.
Right.
What we have noticed over the last at least 10, 15 years, and we've been noticing in clinical practice, a lot of the practitioners have been noticing this in their practice. But for this to percolate to the societies, for them to do studies and then to make recommendations, it takes years. So we've been noticing for the last 10, 15 years that we're seeing a lot of young colon cancers. And so for instance, in our
young people too?
young people, I meant young patients
Yeah,
with colon cancers. So in our practice, the earliest we saw was age 28.
Wow.
When this woman presented with stage 4 colon cancer.
Wow.
In fact, she was part of a show I did on Fox News where she was participating, and she described what she went through, and she had spread to the liver and other organs. And
Wow.
thankfully, knock on wood, she has made a recovery.
Good.
However, so if you take a look at somebody at 28 with stage 4, so just to explain staging, stage 1
right.
is where colon cancer is limited to the inner lining of the colon, which is also called the large intestine.
Okay.
Stage 2 is when it actually starting to go through the wall of the colon. Because when you go through the wall, you have blood vessels, so you can potentially travel to other sites, so that's called stage 2. Stage 3 is when it's outside the colon into lymph nodes and other local structures. Stage 4 is when it has gone outside the colon into another organ, most likely the liver. That's where they usually go. Okay. So that's stage 4. You can't get stage 5, it's stage 4. So if you had stage 4 colon cancer at age 28, that means cancer probably started maybe 22, 23.
Wow.
So what we're trying to say is that we're seeing a lot of young cancers, and we decided to take a look at that. And a lot of people are looking at why is that? Well, we always knew that colon cancer is a westernized problem. That is, Western societies suffer with colon cancers more than, say, Asian societies. And we used to think it has a lot to do with lack of fiber that they do in Eastern society, lack of water, processed foods that they don't have in Eastern society.
I see.
So we used to think those were the reasons. And
Processed food like McDonald's, I'll say it. You don't have to say it.
well, you don't even have to have McDonald's. I mean, you may think that you're eating really healthy at home, but the ingredients you buy to cook, a lot of them are processed. Unless you have your own farm with your own chickens, your own eggs, your own milk, you're going to get some processed foods. So it doesn't have to be McDonald's. It could be what you think you're cooking healthy at home, but you are getting processed food. So we used to think that, and we still do, but why is it shifting to a younger generation? That's a question still to be answered. There are some good studies being done to talk about refrigeration, because the Eastern societies that I talked about where they had lower colon cancer incidence, now that they have become more westernized, their colon cancer rates, like India, is going up astronomically.
Wow.
And nothing else happened, but they became more westernized. What does that mean? Well, that means that they have leftovers. So now you're looking at refrigeration as an issue, because when you eat food just for the day, many people in Eastern societies don't even have refrigerators because they don't need it. They get fresh food every day.
Right.
They finish it, and it's done.
It's like the Mediterranean also. They
Right,
have fresh.
exactly. Now you're westernized, you go to work, come back late, you don't have time to cook, you want to have leftovers, so you need a refrigerator. So now they're looking at refrigeration as an issue which could potentially bring out the toxins that could potentiate cancer.
Wow.
Furthermore, again, when you become westernized, you are eating more processed foods. You're not eating the fresh organic stuff that you used to eat because you have no time. Now you go to supermarkets and you get processed food. So we're looking at all of those issues as to why it's happening, but we do know it's happening, and that's why the American Cancer Society moved it from 50 to 45. In our opinion, it could have even gone to 40, but they moved it to 45, and the United States Preventive Services Task Force agrees that it's a good recommendation. So now we're encouraging people to start screening at 45. And if you had family history, it'll be at 35.
I see. If you're out there, and I know the virus has made you stay at home, you're still doing colonoscopy.
Yes, this is one of the major pushes that has now been taking place. Aside from the interviews I've given, there are a lot of centers now trying to allay any anxiety to the population about getting their routine health care, because it is true that we hunkered down with COVID, and we should still be very careful social distancing, masks. I mean, we're 6 feet apart. We can take the mask off, but otherwise, we should follow all those guidelines,
right.
yes. But don't give up on your routine medical care, because what we're going to see in the not too far future is a rise in heart disease, hypertension, cancers of every kind, because you're not going for your routine screening. Maybe you didn't go for your mammogram, you didn't go for your prostate check, you didn't go for your colonoscopy,
right.
and those cancers are going to go up. You didn't go to check your blood pressure, you got hypertension, silent killer, heart disease is going to go up. So every medical center, university, hospital, practices are now encouraging citizens to take care, but not to delay or deny your routine.
Because in actuality, what happens is that the people that have these problems and delay it will go to the emergency room, and that'll back up the emergency rooms.
Well, not only will it back up the emergency room, it may be a bit late. Like if you go in with a stroke symptom, which you could have prevented by, maybe reducing your blood pressure 6 months ago,
Right.
you may not have had that symptom. Number two, you may go in with some symptom of a stage 4 cancer when you could have actually had the cancer removed. Remember, colonoscopy is the only screening test that actually prevents cancer. What I mean by that is there are a lot of screening tests for cancer, mammogram for instance, and it'll detect breast cancer. And if you do, then if it's early stage, you take care of it, great. But in colonoscopy, you detect polyps, which are benign. They're not cancers, but they're the ones that go to cancers. So if you remove the polyps, the benign polyps,
Right.
then you're not going to get colon cancer. So that is what I mean by this is the only preventive test, not just a screening test. Yes, we'll know if you have colon cancer, but we can also prevent it by removing the lesions before it goes to cancer.
My cousin's best friend died of colon cancer in Colorado, and my cousin was upset because he never got a colonoscopy, and it's heartbreaking, because he was young,
Of course.
So
It's a preventable cancer.
yeah, exactly. So if you're out there, call up your doctor, set up a colonoscopy with a doctor. They're seeing people, right?
Yes.
You have to get a COVID test before.
So we're taking all the precautions.
Okay,
In our center at Middlesex in Acton,
right.
First of all, it's an outpatient center. You don't have to go into the hospital. We do it in our own place. And the precautions we have taken are really above what you need to do, but we want it to be safe and we wanted a good experience. So every patient who comes in for a procedure, we do about anywhere from 40 to 50 procedures a day. And we test everybody 48 hours before for COVID, PCR, and they don't come in unless they're negative. And everybody in the staff are negative, and they're fully covered, what we call PPE, personal protective equipment from head to toe.
Right.
And you come in, why are we taking so much precautions? You just tested negative and you're coming in. Well, we're going above and beyond because we test you 48 hours before, and what if 24 hours later you were exposed, but you didn't know it, because there is something like asymptomatic carriers. So we treat everybody as potentially positive even though they tested negative 48 hours ago. So we have full PPE. The rooms are sterilized in between each case. Furthermore, we got these air exchangers. What that means is, because the virus can be in the air and settle, so we exchange the air after each case, after each patient. So the air is sucked out, new air is pumped in, so when you go in, you know it's a sterilized room and there's new fresh air that nobody else breathed beforehand. So we're taking all of these precautions, and so we're fully up and running with these precautions.
Good, good. If somebody young has symptoms of colon cancer, what should they look for?
Well, young or old, symptoms of colon cancer are unfortunately a bit late down the road, because remember, you have this hollow tube called the colon, and there's a growth, a polyp, which is benign, as I told you, and then over time, it degenerates into a cancer. Well, until this cancer gets so big that it blocks your colon and you have pain, new constipation, or blood that you can see, by then,
In your stools?
in your stools,
Okay.
then it might be a little late.
Okay.
But yes, even then it should happen. But these are some of the symptoms. You could have abdominal pain, constipation, bleeding, sometimes weight loss, and these are very concerning symptoms and should demand an immediate investigation. But young people, we take the risk-benefit ratio. Let's say you have somebody who's 20 and they have some symptoms. Well, yes, it's possible, having said what all I said, that it could be colon cancer. That's not the first thing you'll jump to in a 20-year-old. Whereas somebody's 50 with these symptoms, no question, next day they're getting a colonoscopy. So you try to do the risk-benefit ratio. Do they have any family history? How long have they had these symptoms? And you go through that line, and depending on that, you may choose to treat them conservatively or do a colonoscopy immediately.
I see.
So that's how we walk through that when we
Right.
see a new patient.
I see. There was a Hollywood actor, Chad Boseman, right? He died in August 2020 at 43 years old. What happened that they didn't catch it that early? What do you think happened, or what did you read?
Well, what I suspect happened is this. He is one of those unfortunate people who got colon cancer young, and he was not in line for screening because he died at 43, so which means I predict that he probably started having the cancer around 37, 36, 37.
Wow.
It takes a few years for it to grow and get to that level. And so he was not in the screening guidelines. He may not have had family history. He was busy with his career. He may have blown off some minor symptoms. I don't know. I have no idea. I'm not involved. But I'm just predicting that by the time he got evaluated, he was probably in stage 4 colon cancer, and he was getting his therapies, but he didn't survive, and that's why he died so young. Yeah. When celebrities get cancer, there's always a dip in colon cancer a few years down the road. It started with Ronald Reagan. In the 80s, Ronald Reagan had a colon polyp. Nobody knew what a colon polyp was. He had a colonoscopy when he was president. They found polyps, they took it out. Right. Benign, no cancer. But of course, the president has a colonoscopy. Everybody wants to know what the heck it is. And so they found out this is a way to prevent colon cancer. So if you look at the colon cancer incidence rates, after Reagan had his polyp, maybe 3-5 years down the road, the incidence fell because people went in for their colonoscopy screenings.
Right. Good point.
And that stayed for a while. There was a small blip down with Darryl Strawberry, but the biggest dip down was when Katie Couric had her colonoscopy on television, because she was very popular.
Right.
A lot of people watch her.
Right.
And respect her. And her husband died of colon cancer. She's a strong advocate for colon cancer screening. So she decided, how do I get this message? I'm going to do it on television.
Right.
So she did. And the biggest dip in colon cancer deaths was a few years after Katie Couric had. So yes, celebrities, when it comes to the forefront, we're living in a 15-minute news cycle. So unless you are really actively engaged, you're not thinking about it, and then you let a few days go by, life gets ahead of you, and you say, okay, I'll put it off, and this is what people do. So
how long does the procedure take in your office?
So in the endoscopy center, the procedure itself, the actual procedure is probably 20 minutes.
20 minutes, okay.
You invest a little time before, a little time after, because the nurse talks to you. We do all the checks, we do the IVs, the anesthesiologist talks to you, and then I talk to you. Then we take you into the room, do the procedure, then you recover. Then we all talk to you again, and then you leave.
Right,
So
but you can't drive.
Can't drive.
Can't drive.
Because we sedate you for the procedure, and you want to be sedated, and it's probably the best sedation you're going to get, because you know it, you're completely asleep, you don't feel a thing. Right. And you're mostly awake, but legally we cannot let you operate a vehicle or make some important
Right, so
decisions
in other
that
words,
day.
somebody has to drop you off and pick you up.
That's right.
And you can't use Uber.
We discourage that.
We discourage that, okay.
Because ideally, once you get dropped off by Uber, if something happens to you, there's nobody at home. So we encourage that somebody should take you home and hopefully be with you, not right on you, but somewhere
Right.
close by in
Right.
case you need.
Right, okay. What is the procedure to set up the prep, they call it? Explain the prep. We have 4 minutes.
Yeah. So the prep is basically to get the colon ready for visualization.
Right.
So if you were to take a hollow tube like the colon, which main job is to absorb water and discard the stool or the non-essential food stuff is being excreted, we want to clean out the colon.
Yeah,
So
really
when
good.
when we put a tube in to look, we want to be able to see because the lining of the colon is where the growth starts. So if you have not evacuated the colon completely, then there may be residue and you may miss something. So that's why
You as a physician.
yes,
that's-
I may miss something.
Yeah.
So that's why we say we need a good prep. And you know, because we do 50 cases a day, we have a lot of experience in what is a prep that patients can more tolerate than not. No prep tastes good, I'll tell you that. Anybody tells you anything tastes good, it doesn't. There's no free lunch. You got to take something to clean out your colon. And then we see what our doctors feel is a good prep and what is safety profile. We take all of this into account to recommend the prep for you. In the past, it used to be even worse. It used to be a big gallon of stuff you cannot drink. Now it's 2 small bottles you drink and plenty of water.
Yeah, plenty
So
of
it's much better, but still,
It has a cherry flavor, some of them.
yeah, you can have flavors.
Yeah.
It's not the best part, but it is an essential part.
It's important to clean it out completely because then you can see it with the scope.
Right.
Is that my understanding
Exactly.
of it? Yeah.
Exactly.
So you don't want that brown.
There are only 2 factors in missing lesions. One is poor prep, and 2, the ability of the physician doing it. These are only 2 factors.
Right.
So if you have a good prep and you have a good physician doing a complete exam,
Right.
you shouldn't miss.
Now, polyps, most people think polyps that stick up, but there are other polyps that are flat.
That's right.
Is that correct?
Yeah, you could
And
have.
what happens when you see those polyps, the ones that's like a tree and the flat ones? How do you get rid of them?
So either way, what we do is, what you talk sticking up looks like a mushroom, and they could get quite big, but they're actually less dangerous than the flat ones, because the flat ones, they don't stick up, but they're sort of close to the surface, and you have to delineate where the polyp has grown, because you want to remove all of that area, because if you leave a few cells, they may grow back, and you have to recheck. So, and then removing these polyps, the flat ones, is a little trickier technically, but it can be done. You know, we have various techniques with snares and forceps.
Yeah, right. Yeah, so I just wanted to thank you for coming on the show and explaining what colonoscopies are and what people should do, and you're still doing them, and people are still doing them.
Oh yeah, we're full. People have, you know, again, I think that they feel very comfortable with the cautions we've taken. They feel very comfortable going to a place outside the hospital and into an ambulatory setting.
Right.
And they know our track record, and so we're full. People are coming, and I'm glad, because I think that the tide has shifted where people feel comfortable getting their health care. And you know, Dean, it's always a pleasure being on your show. I've been here a couple of times, and you know, the more awareness, trying to help the population.
I agree. It's a preventive medicine in regards to your health. It's like getting shots, right, in regards to your health care.
Right, it's a preventive procedure, yes.
So go out there, call up your doctor, get a colonoscopy, please, so we could see you next year, the year after, and hopefully everything is going well with you this year, 2020. And thank you for coming. I appreciate it very much.
My pleasure.
It explains, I shake your hand, but I can't do it.